Right, let's start. Hello, everyone. Welcome to our webinar on the draft interim block exemption regulations on price setting in the healthcare industry. It is great to have you here with us today. We have guests from around the spectrum, all areas of the supply chain, as well as a lot of lawyers and economists and also regulators across Africa. So again, you're most welcome. A special word of welcome to Elsabe Klinck and Professor Nicola. Elsabe is the Managing Director of Samuels and Klinck, and she's a legal expert in the healthcare industry. And Prof. Nicola is an expert competition economist at FTI Consulting. Thanks so much, Elsabe and Prof. Nicola, for your availability to join us for a webinar today. Just a couple of questions or arrangements. Please jot down all your questions in the Q&A section and not in the chat function, please. We will not be monitoring the chat, so all your questions in the Q&A. And if you can please leave your questions until the end of the session. There's quite a large number of attendees, so it will be better for us to address all the questions at the end of the webinar. Today's agenda will look like this. I will start out with a short timeline in relation to all of the major events in the healthcare industry that pertained to attempts to first disable and then to enable collective price setting and other activities related to terms and conditions in the healthcare industry. And thereafter, Elsabe will share her input. She will consider in relation to the block exemptions various concepts, to whom it applies and to not, who are in, who are out. She will consider conflict of laws and also consider what did the Commission's Health Market Inquiry consider. And lastly, Prof. Nicola will also consider the exemptions from an economics perspective. Right, let's start with a timeline, and I'm going to share my screen with you. And I'm just going to enlarge it. Right. If we start at the pre-1998 point in terms of the timeline, before 1998, price setting in the healthcare industry in South Africa was normal practice and it was not regulated. And billing guides were published and contained quite a lot of information. For example, fees and codes and descriptors of activities and modifiers, relative value units, the SAMA guideline fees, and so on. So it was quite detailed information that was shared pre-1998. Then, in 1998, the BHF was established, consisting of the former Representative Association of Medical Schemes plus the Healthcare Funders Association. And BHF and SAMA always negotiated collectively, but interestingly, they never really reached agreement. So they published separate billing guides or fee guides. And then there was also a third tariff, which was the HPCSA ethical tariff, which was published in terms of Section 53(3)(d) of the Health Professions Act. And then also in 1998, there was a big regulatory change in the landscape, the legal landscape in South Africa. The Medical Schemes Act came into effect, and 10 days later, the Competition Act also came into effect. And then in 1999, when the Commission was established or became operational, the Commission commenced investigation into collective price setting in healthcare. And the Commission then eventually determined that the collective price discussions between BHF and SAMA was anti-competitive, and all of the parties settled with the Commission, and they imposed various fines. Parties were prohibited from engaging in certain activities collectively. This included price negotiations, but the prohibition also covered conditions of trade, which could imply collective activities on, for example, code sharing, although that is not too clear. Between 2004 and 2006, the Council of Medical Schemes established the National Health Reference Price List, And that was based on an agreed list of services and standardized coding. But this was taken to the High Court, and in 2010, it was declared invalid by the High Court. It was determined that the National Department of Health went beyond what the National Health Act allowed. The department set prices. They did not create a reference. They did not consider the submissions of parties. They added additional rules in guideline format instead of regulation, making it legally unenforceable. They incorrectly linked data collection powers with price determination powers, which are distinct legal processes, and they also did not update the codes to keep pace with medical science. Also in 2010, the CMS and the NDOJ published a discussion document which was called The Determination of Health Prices in the Private Sector, but this document was never implemented. Now, between 2009 and 2011, the BHF exemption, well, an application for exemption was rejected. An application for exemption submitted by the National Hospital Network was granted, and then an exemption application that was submitted by the Health Professionals Council of South Africa, the HPCSA, that was rejected. So there were also not consistent granting of exemptions. In 2014, the Competition Commission's Health Market Inquiry commenced, and that focus was on the private healthcare sector. The market inquiry focused on healthcare facilities, which included mainly hospitals and day hospitals, providers like specialists and general practitioners, the funders, for example, medical schemes, the medical scheme administrators and brokers, and it also focused on the regulatory structure of the market. Before the conclusion of the HMI inquiry, a couple of things happened in 2018. The first was that the National Health Insurance Bill came up for comment. Also, the Medical Schemes Draft Bill came up for comment. And then the Healthman and South African Private Practitioners Forum established the South African Classification of Healthcare Interventions, or SACHI, which is a non-profit organization to achieve alignment on coding. And in 2018, there was another conditional granting of an exemption for National Health Network. In 2019, if we start there at the top, the National Health Insurance Bill was presented to Parliament, and then also the Competition Commission confirmed its healthcare inquiry findings and its recommendations. And among other things, it highlighted various regulatory failures in the healthcare industry in South Africa, the private market. Pricing and licensing were indicated as the biggest problems. They proposed a supply-side regulator for health. They raised the possibility of the establishment of a multilateral tariff negotiation forum, which is a term that also features in the latest block exemptions. They proposed the use of alternative reimbursement models, and they suggested an interim solution, which is to use the National Health Act provisions to allow the CMS to implement and manage the process in the interim. Which is quite interesting, is at the Health Funder Association Legota in 2021. The previous competition commissioner, Mr. Timbinkosi Bunankeli, said players in the healthcare market can apply for exemption in terms of the provisions of the Competition Act in the meantime. But you have to show how the conduct will benefit the economy across certain factors which are listed in Section 10 of the Act, which subsequently have proven to be a little bit more difficult than initially thought. But importantly, he also said that the HMI recommendations are a set of interrelated interventions designed to promote systemic changes to improve the industry, to create a shift towards a pro-competitive environment, not only tariff determination. He said these recommendations must be seen as a package. And he said market failures may persist if a partial approach to the implementation of the proposals is adopted. In 2020, COVID struck, and the COVID block exemptions were issued along with various other exemptions by the Competition Commission, including the fixing of the PCR test price at 850 in March 2021. 9 months later, an agreement was reached between the Commission and the top 3 pathologists in South Africa to lower the price to 500 Rand. Fairly recently in 2023, 35 medical schemes submit a complaint against some of the pathologists for the excessive margin that was made during that interim period. In 2023, the NHI was approved in the National Assembly, and it stopped its reforms. So no longer did the Department of Health pursue the particular reforms that was in place at that time. He said that the NHI will be used to implement the HMI, the Commission's self-market inquiry recommendations. And yeah, it dropped the medical schemes reforms altogether. In 2021 to 2023, a couple of exemptions were granted and extended or amended, and those are for day hospitals, the Hospital Network, and Marang Health. In 2024, the Commission referred the HPCSA to the Tribunal in relation to ethical rules, but those issues had already been amended at that point, so that wasn't an issue. And then in 2025, there were a couple of exemption applications. The Orthopedics Association had an application that was rejected due to a lack of designation. The BHF had an application for exemption which was rejected because there were no evidence of benefits to an industry that was in decline. And the Independent Practitioners Association Foundation, they had partial luck with the Commission. Central buying was exempted from the Competition Act, but co-bargaining and fee talks were not allowed. And then, lastly, on the 14th of February this year, the DTIC published the interim block exemption regulations on price determination for the healthcare sector in South Africa, which is the topic of today's discussion. But if I can just quickly give a color code to all the events that happened. As you can see, the green ones pertain to efforts to structure the industry in terms of a collective approach to fee determination, and the red blocks give an indication of efforts to break it down, whether per regulation or perhaps due to incomplete legal processes or other reasons. For example, exemption applications that can only be approved based on a very narrow set of conditions. This is my intro, and I'm going to give the floor to Elsabe, who's going to provide more information in relation to the very last issue that we discussed, which is the draft interim exemption regulations. I'm going to stop sharing my screen, and Elsabe is going to share her screen. Thanks, Elsabe.
That's a really rookie mistake, talking and not being on. So good. Can you guys hear me?
Yes. Yes.
And can you see the screen?
Yes.
Okay, good. Great. So just a preface here, I'm not a competition lawyer, so I know preciously little about the Competition Act, but I've been working in the health sector now for 25 years. So I think I understand how the health sector stuff works, and that's my perception on this. So for me, this is to be or not to be. So what will this block exemption bring for the private healthcare sector? So I'll cover basic concepts and who's in and who's out in this. I'll talk a bit about candles and cabbages. And I had to research my idioms a bit on that because the Afrikaans idiom is about cabbages and the English one is about candles. And then I'll talk about conflict of laws. I'll talk a little bit about what the HMI recommended, but Prof. Nicola is way more clued up on all of that. And then just a few thoughts from a non-competition law person on what I read in that amendment to Section 10 in terms of the block exemption. Or you could also entitle this of cabbages, candles, cocktails, and cherries. Okay, good. So what is in there? And for us in the health sector, a lot of this is known. There's something in that document that talks about tariffs. And tariffs are basically the fees that doctors or physiotherapists or occupational therapists or dentists and so on will charge. Now, each of those charges will relate to a professional activity. So it will have a code, and that code will tell you that this is the thing that the doctor or the physio did. It will often say how long it takes to do it. It will say how intense it is. It will give you all of those details. And it is largely a technical exercise, and it's also a professional exercise, because it is only the profession that can tell you to manipulate somebody's left shoulder and their right shoulder takes this much effort, and you need a bed like that, and all of that. It's by its very nature something that is set by professions. And it also has relativities. So it will say, this thing is easy to do, and that thing's really difficult to do. This one's fast, that one isn't, and so on and so on. And this differs from profession to profession. And I think there's many professionals on the call today that could attest to that. So it's a wide variety of things. If you are a nursing practitioner, for example, it would be different to when you're an audiologist. So it's quite a complex system that we have. Then the exemption, in my view, surprisingly talks about formularies, protocols, and treatment guidelines. Now, those are also scientific activities. So in all countries in the world, there would be a publication that says, to treat a patient with diabetes, you do this, then you do that, and then you do that. And then if somebody doesn't react to this medication, they take that medication. It's a whole process, and it's often driven by professional societies, and it's published in academic publications, and it is underpinned by research. It's not we agree, okay, we like this, or we don't like this, or this is too expensive. It's a scientific thing, and it is underpinned by clinical research. So for me, that was surprising to find it here, because if we think about diabetes, for example, the SEMSA guidelines is there. It's always been there. We've got hypertension guidelines. I never saw that as something that is anti-competitive and therefore meriting an exemption. However, after yesterday, when the minister spoke, it became very clear that the minister believes that there's overutilization or incorrect utilization of products and goods, and people are doing things unnecessary. And he had a number of anecdotes on medical devices, for example, and people, you acquire the device and then you work it like there's no tomorrow in order to make back the money from it. So I understand why it's included from that point of view, but I don't agree that it's included. I don't think it belongs here. Then health technology assessment is in there. That's also a very scientific process and economic analysis. There's various approaches to it. In most countries, it's an entity that is separate from funders, and funders then consider that if they make decisions. Is it better to fund this in this way or to fund it differently? And then it talks about PMBs and non-PMBs. And PMBs are the stuff that all medical schemes on all options must fund in full and without copay. So it's a legal obligation. And there's a whole set of rules around that in the medical schemes regulations and in the Act. And then it also says it will cover non-PMBs. So so it's really important to understand the difference between codes and the PMB. So a PMB relates to a diagnosis, a condition. That's the diabetes or the hypertension. A code is a visit to a GP or a visit to this, or it's two different things. So PMBs would need to be associated with certain codes. So you'll have a GP consult, could be for a PMB. If I go to the doctor for my osteoarthritis, it will not be covered. It's not a PMB. Or osteoporosis. If I go for my hypertension, it will be the same tariff code, but it will be one will be for a PMB and one will be for a non-PMB. And then the provision also talks about, the document also talks about quality matrix, and it puts in the Office of Health Standards compliance in there. When the minister spoke yesterday, it seemed as if he was rather referring to outcomes measurements and not the quality is in terms of, is your hospital clean and do people properly consent and all of that. It seems to be much more on, is your diabetes adequately controlled or not? Now, the main thing in this document is who will be involved. It talks about healthcare providers. And healthcare providers is not only doctors and it's not only specialists. So, and this is what we see in particular if people comment on this, they kind of assume that this is about the specialists. This is about everybody. It's about the nurses. And we know there's nurse practitioners in many places. It is about the pharmacist services that are not related to medicines dispensing. It's about social workers. So it's massive. It's about medical technologists and clinical technologies, the people that operate the machines. If you do a heart transplant, for example, the perfusionists that operate those machines. It's about everybody. So it's wide. Then the document talks about funders, but it doesn't define it. So funders could also be a gap cover insurer in effect, and not necessarily a medical scheme. It could be the compensation fund. They're also a funder, but yeah, we're not sure. It also talks about other stakeholders. And that's where I think there's people that are implicated in this, like everybody who appears or don't appear on a formulary is implicated. Everybody who appears or don't appear on a treatment guideline is implicated. And that's what I think the other stakeholders refer to. Then there's the two abbreviations of the one is a tariff governing entity that the minister will appoint. And the other one is that multilateral tariff negotiation forum. So, and both of these bodies will be appointed by the minister. And that's also what makes people a bit uncomfortable about this, because it actually doesn't really say who these people would be, what process we will follow to get there, what their mandate would be. And given this number of providers that will be affected by this, I mean, I haven't even mentioned the people that deal with donors, organ donors and bone marrow transplants and so on. I didn't even put them there, but they're also important. Then there's two committees that we know as so-called MACs, Ministerial Advisory Committees. The one is the Coding Committee, and the other one is the Health Technology Assessment Committee. They are established by the Minister of Health in terms of the National Health Act, and they advise on these things. And it kind of, this document says we could refer things to them and they will advise and they will input, but the exact relationship is not clear. And for example, if we talk about practice code numbers, that is something that the BHF is currently running in terms of the Medical Schemes Act. And then it does refer to the Office of Health Standards Compliance, which has a massive mandate in terms of the National Health Act. And they're fulfilling that. You can look at their website, how facilities are doing, and they'll start inspecting GP practices very soon. I just made a reference there to the practice code numbering system, because don't confuse that with the tariff codes or the billing codes. That is an entity to claim from a medical scheme. You must have a practice code number. So that's another complication in all of this. And you'll see the exceptions of who is not governed by this is actually in there. Okay, that was just my fancy way to see if I can work with animations. So who is excluded from this? But to be excluded doesn't mean you're not affected. So, and per those PCNS codes, those practice code numbers, they actually list them and say, if you have this practice code number, you're not covered by this. And it's basically hospitals, rehabs, mental health facilities, and it talks about unattached operating theatres. But some unattached operating theatres are actually attached to practices and are not in hospitals. So there's a bit of a discrepancy there. And then, of course, if there's global fees, a global fee would attract to the facility. So it would be, for example, a cardiothoracic surgeon, an anesthetist, the hospital, afterwards the physio perhaps, or whoever's responsible for the rehab of that patient, the perfusionist, all of that. And this will be one fee for all of those together. Now we're saying in this system that part of it's not there. So there is already alternative reimbursement methodologies and mechanisms in place, and there's global fees and per diems and things in place that actually goes beyond just the healthcare professionals' fees. And then it says tariffs and codes for medicines are excluded. Now the codes for medicines are NAPI codes. And that's very clear. And medicines have got a single exit price and it's not up for negotiation. And that's understood. However, consumables for devices, so swabs and stitches and things, those also have NAPI codes, wound dressings and things. But they are included in this. So you have this discrepancy. If you're in the pharma industry, your prices won't be at stake here, but if you're in the devices industry, it would be. So the whole devices industry is not mentioned here, but they and their products will definitely be affected. So the pharmaceutical industry is implicated through the formulary, because the moment if you set a formulary that excludes a particular product, then you've affected the access to the market of that particular entity, but they're not involved here. And also the health technology assessment process. If that inputs into this and it says, oh, this drug is just way too expensive, it's not worth our while, worth our candle, I believe is what you say in English. But then you can be included or excluded. You're not mentioned in this document, but you're implicated and you're affected by it. The same with people think pharmacy is excluded. Pharmacy is only excluded insofar as medicines and medicines tariffs and things are concerned. So the dispensing fee. If a pharmacist renders primary care or pharmacist-initiated management of antiretroviral therapy, sexual health, those things for which they can charge a professional fee, that's also now up for discussion. HTA are assessments on medicines, medical devices, and even procedures. Is this procedure better than that one? And then just also remember, certain medicines have an administration cost, certain devices also. The professional, because they're using it or administering it, like an infusion, there's a cost involved in that. There's a professional activity involved in that. And that also, so there's things that relates to, and if we don't pay people for administering the medicine, we may find that the medicine is not being used in the end. So there's that group that's excluded but implicated. Then there's the perhaps excluded but definitely affected, and that's the medical devices. And I think we need to come to grips with that. Drips are also yeah. So this is really important. How are we going to handle this? because there's NAPI codes for consumables and disposable medical devices. There are higher fee codes for the use of a particular piece of large equipment that you had to buy. And here it will now be interesting, because if the equipment's owned by the hospital, it will be out. But if the equipment's owned by a practitioner, it will be in. So there's a discrepancy in that regard as well. So to the candles and cabbages. So in Afrikaans, we said the cabbage is not worth the sauce. In English, they say it's not worth the candle. So the question is, will the system that we're now putting up for the next 3 years, from whenever it comes into effect, is it worth our while? And this is my C's relating to this, the cost. What will this cost to do? This large database that will be set up at the CMS, the potential of them asking for line-by-line claims information, all the people that will sit on these, all the people we know with a reference price list, the cost of doing a practice cost study for a profession, that has been massive. So the cost of this, will it be worth it? The complexity, all of these professional societies, the nurses, the pharmacists, the various specialist groups and subgroups, the physios, the biokineticists, all of them. And then everybody implicated. How do we manage the device and the pharmaceutical industry, and everybody else that kind of is implicated in this, but they're not really a party? Then also dealing with disputes. That was the thing that previously in the timeline that Odie showed was problematic, as how we managed that kind of disputes, the complexity around that. Somebody says, the minister yesterday said the doctors lied on their practice code, their practice cost studies. So how will we manage that? And then the cycle, when do we start negotiation? Because remember, medical schemes must apply for the approval of their benefits by around September every year. So they need to start working on that. So the question is, how will this cycle then work practically? The courts, will be yesterday also, that was a big thing on who's going to take us to court on this, the minister said. Conflict of laws, and I'll spend a bit more time on that. So is for me a huge and very important thing. Confidentiality versus transparency. So there's talk about how important it is that all of this is transparent. And then there's the competition law bit that says, oh, the information is confidential. So it seems to be a contradiction in terms of, are we now going transparent, or are we going confidential on this? And what will be transparent and what will be confidential? And then also in terms of the data. So you'll see that the Council for Medical Schemes no longer releases the full range of data that we had in the past. So if I don't know whether a medical scheme could actually, or medical schemes could afford a particular service, I can't, or what they could afford, or what the incidence of a condition is, it's difficult to negotiate then collectively what that tariff would be. And then the inconsistency between global fees, value-based contracting, multidisciplinary practices, these global fees, and then the administration costs for medicines and medical devices. So for me, this raises the question, is this complexity, is this the best solution that we have in order to address all of this? That's again me with my animations. So just in terms of what we have currently, we've got a Medical Schemes Act and regulations that already covers formularies, protocols, benefit limits. It's already there, and it says the protocol and the formulary must be on evidence-based medicine, and it says taking into account cost effectiveness and affordability, which is basically HTA. And then it creates a system of exceptions. So the question is, if we're now going to collectively negotiate on what a diabetic patient is entitled to in terms of a formulary and a protocol, where does this leave medical schemes in terms of setting this and exercising their power in terms that they have in terms of the Medical Schemes Act? There's already treatment algorithms for the actual 26 chronic diseases. The DTPs explain the diagnosis and treatment pairs, explain what treatment, and the minister has issued that. Those things are issued by the National Department of Health. They can update them as they should tomorrow if they wanted to. So the question also is, why are we doing this other stuff if we've got that power already? The PMBs and the updating thereof is a huge thing. That was one of the things that the HMI said should be done. And now it's part of this piecemeal thing. Contracting, schemes have got the power to contract with designated service providers, with preferred providers, and those exist currently. There's also a system in copays. So copays is not a swear word. People think, oh, copays is bad. Copays give you choice. Some people will choose to copay in order to access something else. So, and this has been billed as if copays is the biggest disaster ever. It's built into the legislation, this copays. And it says there's circumstances where you cannot be made to make a copay, but in other cases you can. So, and it's also a tool that schemes use in order to disincentivize people and to channel their behavior. Then there's the practice code numbering system Reg 5, and then there's the clawback provision that says if you, as a provider, do something that's not in the scheme's benefits, they can claw that money back from you. There's already that mechanism. And then the National Health Act, the reference price list that Odie referred to and the history there, there's space for regulations on health technology. There's space for regulations on the essential medicines list and the essential equipment list. And then there's the whole chapter on the Office of Health Standards Compliance and Quality. And the question then is, if we've got the legal frameworks for all of this, why are we doing this other thing? There's also the Health Professions Act, and this is the law that says who's got the power to make pronouncements on what it means to diagnose a diabetic patient, to treat a diabetic patient. The HPCSA has also got rules on fees and consent, and they're now very strict on informed billing consent. And then they've got a business practices policy that says protocols and guidelines must be developed on scientific criteria. So we've got a whole system around that. And then there's HTA, which is a scientific assessment. So my question is this really what the Health Market Inquiry recommended? This is what they recommended. If you want the graph, it's in the 2018 draft version. It's not in the 2019 version, but it sets it out. And you'll see there's distinct units for these things. What now is happening is this all get mixed into a single entity and a single activity. And that was never what was intended. We understand the minister say, oh, we'll never have the supply side regulator for health because we can't have Schedule 3A new entities being put up. But is it really necessary for us to put all of this now in one thing, basically under the guise of collective bargaining or collective tariff negotiation? So the Health Market Inquiry also spoke about the importance of value-based care, alternative reimbursement methodologies, and so on. And that's all now kind of by the wayside. There's a list of what the other things were that they were recommending. Just from my limited understanding, our last thing on competition law, I understood Section 10 is to exempt a practice or an agreement, not to create a new practice and agreement, because that to me is what seems to be happening. It says exactly this is how we now need to, we're creating a new thing that wasn't there before. So, and I think that for me as a non-competition lawyer is is interesting. So I call this the exempted but prescribed practices. And then it involves others. And it has implications for existing agreements and existing practices in the market. So the DSP, designated service provider contracts, preferred provider, managed care contracts, managed care organizations that currently put up a particular offering that schemes then say, and they manage the care and the cost for a scheme. And then interesting, it doesn't give exemption from collusive tendering. And many medical schemes, so GEMS, for example, issue a lot of tenders. And the question then is this, and what will this exemption now be versus this tender? Because you'll tender to see the, let's say, mental health patients at a particular tariff in terms of certain conditions. So that's then the end of my story. I'm sorry, Nicola, if I went way overboard.
Thanks a lot, Elsabe. It was great and very insightful. Nicola, thanks. Really looking forward to listen to you.
Thank you very much. Good afternoon, all. Thank you, Odie, for organizing this webinar. It's clearly a very important topic. We look at the number of participants and the comments of the press. I'm going to also share my screen. There we go. Can everybody see this?
Yes, thanks. Thanks, Nicola.
Get it, yeah, on full screen. Okay, so the question was also asked, why now? So Elsabe asked the question, why do we have these block exemptions now? 14th of Feb 2025. Also, please just note these are draft block exemptions. So there is 30 days for comments, which I think we should all endeavor to give comments and see if we can impact on some of these uncertainties that were raised by Elsabe as well. But there's no doubt that the overarching goal here, as also stated in the preamble to these regulations, is ensuring that the sector can transition smoothly into the NHI framework. And this is where I want to give some comments from an economic perspective, because essentially, and I will also go a little bit through the history that Odie has emphasized, but essentially what government is trying to set up is a bargaining framework. So there are demand side factors. The funders buy from the providers. So the supply side is the providers. As Elsabe has pointed out, not only GPs and specialists, obviously also hospitals, they are exempt for the moment from these block exemptions. But government is essentially trying to mimic a market mechanism here. And it's interesting because if you think about the history, if you think, for instance, I've been involved right from the start, for instance, with single exit pricing litigation, the NHRPL litigation, the NHI features in here in terms of how the NHI fund will procure from these providers. And then obviously also one wants to look at the HMI. So what you have here is an attempt really to allow for certain parties to be exempt from Section 4, essentially, and Section 5 of the Competition Act. So as we've seen before 2003, and I'll get to that in a second, there were collective bargaining on both sides, so supply side and demand side, which balanced the market at the time. When that was declared illegal, there were various attempts to try and get to a system that would balance the market. But maybe let's just look at what is proposed in these block exemptions. So the first thing to mention here is that obviously we are told that the aim here is to have affordable and accessible quality healthcare. So universal health coverage will come. We know that the NHI Act has been signed, will be implemented. The question is how. And government, the NHI fund, and I'll get to that a bit later, has to procure from these providers, and it will be in their interest to try and control prices and tariffs and costs on the supply side. And that's essentially what this is trying to create here. So the collective determination here will be tariffs for healthcare services. Elsabe has explained all these things. standardized medical device procedures, treatment codes with all the challenges that imply, and then quality metrics. But the important terminology is this multi-stakeholder tariff determination framework. So it will be various stakeholders, as I've already mentioned. The hospitals are excluded currently. Range of facilities are excluded. But the intention then is this equitable and transparent framework for tariff determination. The long-term goal is reducing cost, promoting universal access to health, and enhancing quality of healthcare. So like anything, good intentions, but once one gets into the detail, it becomes very clear very quickly that it lacks detail. I will also answer the question whether this is in line with the HMI recommendations, and I will show that the HMI recommendations were much more detailed. This takes a subset of those recommendations and water them down effectively to something which is not going to make sense if it is applied in isolation. So Odie has already covered that, but I think it's just important to point out a few things. So as I said, from an economic point of view, on the left-hand side, you can see the graph there. So I have the funders on the one side, the medical schemes, the providers, the hospitals, the practitioners, and these have to balance demand and supply in order to determine tariffs. And we all know that healthcare costs should be contained. We know that consumers, insured, have to pay their medical scheme premiums, and obviously it's in the interest of everybody to roll out universal healthcare coverage, but the question is, how do you do that? So prior to 2023, as we've already heard, it was RAMS that then became the Board of Healthcare Funders. We had the medical practitioners, SAMA, and then we had the Hospital Association. Interestingly enough, the latter had permission to publish a reference price. In 2004, which was correct, the Commission came to the party and said, well, this collective bargaining that is carrying on is in contravention of the Act, Section 4 specifically. So no exemption was then given at that stage, similar to what we have now. It was simply declared illegal as a restrictive practice, and that obviously created this whole vacuum. So I think it's so important to understand that we've had this vacuum. As Elsabe pointed out, there are various pieces of regulation and legislation that cover some of these aspects. But in terms of collectively bargaining and trying to balance this market, there was really a vacuum, because in that period then after 2004, we saw the whole litigation around the reference price list, the National Health Reference Price List. That didn't yield any results. In fact, specialists and hospitals generally asked prices that deviated from the RPL, applied balanced billing, consumers had to pay out of pocket, and the government then tried to step into this void. They've been trying for a number of years. So the exemptions that we see now, the block exemptions, is just a further step in terms of government trying to step into this void and to create this bargaining framework. Odie has already talked about the 2010 document. So when the RPL process ran aground, the Department of Health again stepped into the void with the CMS. They published this discussion document, Determination of Health Prices in the Private Sector. And this is just from that 2010 document. So you can see always this idea, the Minister of Health, some steering group, the HPCSA, the CMS, getting everybody around a table, a consultative forum. So these ideas are not new, but they have been fraught with difficulties, as you can see there. Now, just from an economic point of view, and I'm not going to go through all the bullets, it will take too much time. I think we will make the presentations available afterwards. But what I want to illustrate is, do you want a regulatory framework that is supposed to mimic the market? Or can you have a balanced bargaining framework? Now, what is interesting here is that in the preparation for the NHI, we probably need some regulation on the supply side. There's not a world anymore where we can have a market that just determine supply and demand and prices. But it is interesting, if you think about the exemptions, and I'll get to that in a second, that there have been quite a number of exemptions. So there was this recognition from the Competition Commission that some parties need to negotiate collectively. Take, for instance, the National Hospital Network, the NHN, which is a loose collection of independent hospitals. There was a recognition that they can negotiate collectively. So their successive applications for exemption have always been approved. But there's always been a different view as the market developed. So in 2003, for instance, you had many more medical schemes than we have currently. So on the right-hand side, old graph, but you can see the consolidation there in terms of medical schemes. So at one stage during the earlier mergers, for instance, before the Competition Commission, the tribunal said medical schemes have countervailing buyer power. So from an economic point of view, that's a good thing. So you want to balance this market, there's consolidation on the medical scheme side, they force down prices through their size and their buyer power, which limits the seller power. But that then changed over time. So the HMI then said in 2019 that, in fact, in their provisional findings already, that they are worried about the unchallenged dominance of a small number of large funders. So as this market developed, you also saw concentration of market power, for instance, on the funder side. The tribunal in the Mediclinic and Matlosana Health merger that went right to the Constitutional Court also talk about the inefficiency of medical schemes. Interestingly enough, when you look at the BHF exemption, so the funder exemption that was just rejected in 2025, the Commission says, yes, there are challenges for medical schemes. There are fewer schemes now, the graph. There's high healthcare costs that they have to pay. There's lots of out-of-pocket payments. And there's increased expenditure on PMBs. But nevertheless, we're not going to give an exemption. So that brings me to this question of why now? And in my mind, it is certainly because we are paving the way for the NHI. And this is what is said in the explanatory introduction to these exemptions. As I said, can we leave these things to the market? You have to balance all of these different bargaining dynamics and the various market power of these players that can also change over time as the industry develops. We know in healthcare, we've got information asymmetry. You don't necessarily can compare between medical schemes. You also don't know exactly what you require in terms of services from a provider or a GP, for instance. If I go to the specialist, I don't have enough information. So what the IHMI final report says, which I think is right, is they say our recommendations emphasize the importance of creating a competitive and cost-effective supply side. So yes, we need a cost-effective supply side within a coordinated, important regulatory framework that can also contract with the NHI fund and other structures. So typically with medical funds, if Section 33 of the NHI is amended, which hopefully it will be, all healthcare purchases, including the NHI, will require providers to be properly regulated. Any single buyer system like the NHI fund on its own, without complementary supply side regulation, cannot succeed. So yes, there's a need to contain costs on the supply side, and we see this regulatory vacuum. But what is happening in the interim? The issue that I will conclude on is there's very little in terms of coordination here between the various parties. So you see 14th of February, we have these block exemption regulations for certain parties, excluding hospitals, for instance, but against which framework? Because now the problem is that this bargaining balance that you want in the market has already been tampered with. Not because somebody intend to do it, but because of these piecemeal interventions in the market. So just some examples, I've already talked about the National Hospital Network. So that is a collection of hospitals. They can collectively bargain for tariffs with medical schemes, but they can also collectively procure. That's important. So that also gives them some power when they procure from companies that produce medicines or medical devices. The Day Hospital Association has a conditional exemption for 5 years. Maybe just on the provider side, the Orthopedic Association, they applied for an exemption in 2022. The Independent Practitioners Association applied for an exemption in 2022. And if you look at those notices now, where the Commission rejected both of those are published in 2025. So there's been this inactive period. And now, I think because of the court cases against the NHI, but also in the run-up to the NHI, there is this attempt to make decisions on some of these issues. But then you still have, for instance, the NHN exemption, which applies. So there's some strengthening on the hospital side, but on the funder side, the exemption has recently again been rejected. So that is against the bargaining power of the schemes. And then also on the individual provider side. So on the doctor side here, the IPAF and the SAOA, that has been rejected. So clearly it seems to me that there's some notion here. For instance, if you look at the collective bargaining was rejected for the protectionists, the global fee was rejected, but what was approved, similar to the NHN, is the centralized procurement. So clearly, this new regime is supposed to give then collective bargaining power, at least to the schemes on the one hand, and the practitioners or the providers on the other hand. Now, in terms of what the HMA recommended, and I want to contrast that to some of the issues that are being suggested in this document, the exemption document. So what the HMA said is we should have a multilateral negotiating forum that can collectively negotiate, but under the auspices of the supply side regulator for health. So it sounds similar to what we now have, but it's also different. The one thing that was emphasized by the HMI when they suggested or when they proposed this supply side regulator for health, they expressly said that the supply side regulator, the regulatory regime, should be as independent as possible. It shouldn't just sit under the Department of Health. So while the minister, in that case, would have appointed the board, there would have been autonomy then for the board to appoint the chair, the chief executive officer, other executives. However, if you carefully read the block exemptions that we are discussing today, Elsabe also pointed out that the minister will appoint, and then some of these functionaries will all be appointed by the DG of the Department of Health. So to me, that is a big difference. So remember the HMI, I'll get to that in a second, but they considered everything in the private sector, and they came up with this recommendation, but they explicitly said it shouldn't sit within the Department of Health. It should also be independent to the degree that is possible within the legal framework. Also important is that the multilateral forum under the HMI foresee that it would set maximum prices for PMBs, but reference priceless for non-PMBs. And to me, that's one of the biggest differences, because now what we have here is PMB and non-PMB tariffs that will be set. So it won't be a maximum tariff as far as I can understand. It definitely will not be a reference price list. In fact, what we are told is that once these tariffs have been set, and we'll talk about that in a second, practitioners can bilaterally negotiate, potentially with medical schemes, but that will only be then for a lower tariff, can never be higher. Also, these tariffs, I'm not going to go into it, Elsabe also talked about it, but these are highly scientific, complex things to determine. And, you know, these block exemptions talk very glibly about a price cost assessment that will validate the tariffs. So the parties will make submissions, they will give data, it will all go via the CMS, and then there will be a price cost assessment to validate this. I mean, this is highly specialized. You will need to get the right people to do something like that. So then as well, the other thing that the HMI emphasized was this move towards ARM, so alternative reimbursement models. So it's difficult to understand that if you leave the hospitals out, for instance, how are you going to create a global fee for a specific procedure, for instance, where you need the hospital, the doctor, and the medicine included in that global fee. So the HMI was very strong that we need to move away from fee for service to alternative reimbursement models. It's not clear how that is going to work. Funded, and then obviously the HMI also agreed that funders and facilities, hospitals, can continue with bilateral negotiations. They said that there's a balancing of the market there, and we also see this recognition here in the block exemption regulation. So it's the same for hospitals, but the HMI went a bit further to say, well, within 3 years, we want to see ARMs in the hospital sector as well. And then maybe just the final thing, Elsabe also mentioned it, is the HMI also has a long section on preferred provider networks, on DSPs, which they see as very important for driving down costs. We don't see any of that in the block exemptions that we are now discussing. So the other issue which is problematic is, and many commentators have already said that, is that we had the HMI, a comprehensive study that's been done since 2014, provisional report in 2018, final report in 2019. Some of those recommendations were really good. We had health reforms, reviews of PMBs, for instance, which is now included in these regulations, the exemption regulation, but many of these things never happened. The Commission, and this is actually from a presentation done by the Commission, by the previous Commissioner, Thembinkhosi Bonakele, in which he actually reported on progress that the Commission has made. So it says here that the HMA made recommendation for an interim solution. They already started engagement with the CMS. They had a memorandum of understanding. They had engagements with SAMA, the BHF, HFA, Section 27. And then it says finally efforts were made to engage the NDOH to commence the process to establish the forum. And then it stops. So in this interim period then, since Thembinkhosi Bonakele reported this, until Feb 2025, there's again this vacuum. But what is clear, as I've shown you on the previous slide as well, is that what is now on the table is not the HMI recommendations. It's a watered down version of that. I'll expand on that then as a final thought. What was the aim of the HMI? As I've said, the HMI was took 5 years. It was an in-depth study as to diagnose, as it says here, the most probable structural features of the private sector, looking at potential anti-competitive behavior, the structural context, and then to find the most effective solution. So this work has been done. Issues, I'm not going to go through them, but all of these issues are important. And this is the point I want to get to, is the healthcare sector is an integrated sector. So the HMI looked at information failures, funders, healthcare provision, principal agent issues, information asymmetry, market power on the side of medical schemes, hospital groups, pathology firms, market power through collusion, barriers to entry, government failure. So all of these things had to go into the pot to analyze them, and then they came up with a set of interrelated interventions. And this is what I want to highlight here, is that these interrelated interventions was designed to promote systemic change in the private sector market. And these are broader than only tariff determination. So as we showed in the beginning, the block exemptions that we are talking about, they look at tariff determination between practitioners on the one hand, funds on the other hand. They also include quality issues. But the recommendations of the HMI go further, they go broader, and they must be seen as a package. Other important issue, which I don't have time to talk about now, Odie, maybe that's a separate webinar, but this whole idea of a single base package for medical schemes. So that was also a recommendation. Subsequent to the 14th of Feb, we've now seen the Minister of Health with the CMS report on a low-cost benefit package. In the introduction to this, he says, and it's been widely reported in the press as well, that he doesn't even see the need for such a package. But this was, again, a recommendation of the HMI. So these building blocks need to fit together to give us a coherent policy that will contain costs under an NHI. There were recommendations about medical scheme accountability. I've already talked about ARMs. So what is required for better functioning of the healthcare market in South Africa is an integrated approach to regulation, not these piecemeal interventions. So what we have at the moment is regulations that come on top of other pieces of legislation, other pieces of policy reforms, some exemptions in the healthcare sector, and then, as we know, a lot of things that haven't been addressed. So the review of PMBs, for instance, many recommendations that have come also from the private sector that simply haven't been implemented. And now suddenly we have these block exemption together with the low-cost benefit schedules or low-cost benefit options. And these things are clearly an attempt to pave the way for the NHI. But if you do it in such a piecemeal manner, you run the risk of actually disrupting these markets even more in terms of fragmented policy and policy that's not coordinated. Thank you, Odie.
Thanks very much, Nicola. This has been very insightful. Thank you for your thoughts. I'm going to start with questions from the audience. So if you have a question, please type it away in the Q&A part of the Zoom channel. We have a question from Shelley. Shelley says, thanks to both Elsabe and Nicola for great presentations. Why exclude private hospitals and facilities? Is there logic to this?
Yeah, maybe I can take that quickly. I should actually just get to, maybe I'll just get to the relevant sentence quickly. It might be easier. So it says here specifically that private hospitals are excluded. I mean, maybe I'll just read the category of it's not only hospitals. So it says here, for the purposes of this regulation, the multilateral forum will not apply to services provided by health establishments with practice codes XXX. So it's also mental health institutions, subacute facilities, but then importantly, private hospitals, day clinics, hospices. And what it says here is that these practice codes, X, Y, and Z, shall continue to be determined through bilateral negotiations between funders and the respective health establishments. And that is the recognition also of what the HMI found, that because of the buyer power on the medical scheme side and the 4 or the 3 large hospital groups together with the NHN that has the exemption, that these are robust negotiations that can continue in this fashion. So there's some recognition there of a balance of market power in terms of the facilities and the funders. So I think that's fine because it's a continuation of the status quo and it's an endorsement really as to what is currently happening. So I would certainly think that is a good thing.
Right. Thanks, Nicola. Someone asks, would these prices apply only to medical scheme members or does it extend to private paying patients?
Should I take that one?
Thanks.
Okay, so it seems like it's only applicable to medical scheme patients and tariffs, and that then creates an interesting thing for practitioners and I'm thinking about the biokineticists. They do medical scheme work, but they also do a whole lot of work that's not medical scheme work. And that raises the issue as to how one would, from a practical point of view, because you could have one tariff code, but you'll have the determined tariff, and then you'll have so you'll have a medical scheme and a non-medical scheme tariff. And I don't know if that raises issues of fee discrimination or any competitive issue. Odie, I saw that Dr. Aslam Dasu had his hand up. So
Right.
I wonder if he wants to, can he talk? Can he unmute himself?
Please go ahead, Doctor, if you can. Sorry, let me just quickly see what I can do from my side. Otherwise, if you can unmute yourself at this point, you are free to do so. Right, maybe I'll find him here. Oh, there it is. Oh, there's someone. Elsabe, who did you say?
Yeah, Dr. Aslam Dasu. But I see it just says chat, or so I'm not sure if one can, if we can unmute.
Does he?
There he is.
Daar thank you so much. Sorry, Dr. Aslam.
Can you hear me?
Yes, we can. Thank you so much.
Thank you very much. Yes, sorry. I don't actually have a question, but I do have additional information to what was certainly the historic events that led to this tariff imbroglio that we now see.
Right.
I was the inaugural CEO of BHF, the Board of Healthcare Funders, that we formed out of the ruins of RANS. And at the time, it was around 2000, 2001, when the competition law had just been accepted, the new competition law. And our lawyers sent out a brief, and I found I had to sit up straight away. Up until that point, BHF would negotiate with HASA, would negotiate with the private practitioners groups, and set tariffs in the scale of benefits. And that was a practice of many years standing. In terms of the new competition law, that was completely illegal. Mm. And so what we did, the chairman and I, Brian Brink and I, went to visit the competition commissioner and his team, and we told them, this is what we do, and it's not consistent with the law. And by the time they picked their jaws up off the floor, because they had no idea about this, they didn't know what to do. And we said, no, it's okay. We need a year to get out of this situation and then leave it to the market participants to negotiate the prices. And I stayed strong on that particular issue because we were suddenly summoned to a meeting at the Department of Health, chaired by the Director General, Andan Saluba at the time, who said that in terms of and had all of the providers there, by the way, and who said that in terms of the competition law, an exemption can be granted to continue with the scale of benefits negotiations if all market participants agree and the minister of that particular sector, in this case the Minister of Health, would then apply for the exemption on their behalf or something like that, and they would be given the exemption. But they must all agree. And they went around the table, everybody agreed, and we stood our ground, no. And because we didn't agree as BHF, exemption couldn't be granted. Our view, and my view at the time, comes from a very simple principle. Competitors, seek to prevail, not to preserve competition in a market. And therefore, there is a tendency for oligopolies to develop. And clearly, we see that in the private health sector. But at no time was it possible to apply that competition necessity to the health sector. I never saw the need at that point, and subsequently, because I could see the difficulties out of our negotiated tariffs, scale of benefits, that was just uncontrolled. And I could see this difficulty. And what was interesting was that the medical schemes supported this idea that there should not be this collusive bargaining. So BHF and its membership approved that. This was in 2001. So it's not true that the Competition Commission, in its great wisdom, discovered this and in 2004 outlawed it. We made an arrangement with them, and we, for coming forward, were only punished with the grand total penalty of 500,000 rand. The Hospital Association, I knew, paid about 6 million rand, but it was settled. And then only as this government does, the credit was claimed. But over the period, we could see that lots of organizations were capable of actually negotiating these tariffs, because all of the other stuff, the NHRPL and all of those other attempts, there was a single-minded purpose. And that comes from the government, from the Department of Health, which seeks to control the pricing in healthcare. It has always wanted to do that. And we can't understand, well, I know why. There's this control freakery that comes out of its ideological positioning around private healthcare. So that you even see that in these regulations here. The minister will appoint this group, and the minister will do this, and the DG will appoint this. It's all rubbish. And I'm quite happy to say that publicly and to the minister himself. Now, the HMI recommendations understood the difficulties and proposed a mechanism, an interim mechanism, as you quite rightly described, I think it was Nicola, and, hopefully a bilateral situation that could develop. They have now kiboshed that with this regulation, or these draft regulations. And it's all because of a political imbroglio in the government right now over NHI. And we've all seen that, right? The NHI is mired, it can't be implemented, you can't get any tax hikes, you can't even get a 2% VAT hike, as we saw in that fiasco last week. So it's not going anywhere. And it's a face-saving mechanism to say, oh no, now we'll go and use the HMI recommendations. And as I think it was Nicola again who said, well, they're not exactly the HMI recommendations. These are watered down versions to show, that there's still a life in this NHI process. And I don't know if anyone saw this live press conference. The minister of the DTIC couldn't wait to get the hell out of it. He could see this was not going to fly. This was all a health ministry thing. And it is so terrible that the government is now deadlocked on it. The presidency, we know, has agreed that the NHI can't work. It needs to be revised. But the Ministry of Health doesn't believe that. The DA in the GNU was ready to go to court. But of course, as all political parties are, there, look out for themselves. And no, if we tweak this and we tweak that, tweaking a bit of the NHI does nothing for the public health system. You can have medical schemes and they could look after themselves by removing Section 33, but they throw the public health system under the bus. So therefore, we have now the new set of proposals. And it's not new. It comes from what was stopped before that was rolling out, the Medical Schemes Act, and then the supply side regulation after there was risk equalization. And by 2015, we would have had an integrated system of public and private multi-payer system of healthcare, no problem, tax funded and privately funded. So we've picked that up again, looked at all of the historical degradation that has occurred with 20 years of no healthcare reform, and we have now put it together, taking the Taylor Committee of Inquiry, and I hope Alex is on this, Alex van der Heever is on this. He was intimately involved, and if you have the opportunity, let him speak to the detail. Many of the things you've mentioned in that HMI. Got that report. And now the Universal Health Access Coalition, this coalition that we have formed with all health professional groups and others, including the BHF, which has joined it, and the day hospitals, which have joined it, take all of the HMI recommendations, which are a composite set. It's a package. You can't pick and choose what you're doing, which is what these regulations do, and then water it down, all the time trying to disguise the fact that they want total control over these prices. And that control, you can see, is also in the NHI. Single fund appointed under a board appointed by the minister in an SOE model should turn out very well. Shouldn't it? Like that. I mean, are they ridiculous? It's not going to fly. So we've put the proposal forward. It makes absolute sense because we have the Medical Schemes Act. You've got the market as it is, even struggling a little bit with these tariff issues. We understand that. But if you take the entire composite set of HMI recommendations, and all you have to really do is read the preamble written by the judge, our former Chief Justice, who squarely blames the government for its lack of regulation of the private sector that has resulted in all these distortions, and total negligence of the public sector. So we know who the culprit is here. And for them to try and come up with this kind of regulation in order to say, oh no, the HMI is alive and well and we would have done this anyway, is just utter nonsense. We should ignore it. There's only one thing to do with these regulations, and to insist that they withdraw them. You can't fix this problem. Like you can't fix NHI by removing Section 33. The UAT proposals recognize this. It takes the comprehensive approach to the HMI recommendations, puts them in place, accounts for the degradation of the public sector over the last 17 to 20 years, and puts it forward in a framework. The president got it. They sent it to the Ministry of Health, who quickly sent a reply back. It's been noted, but we can't engage because it's sub judice. Their NHI is being litigated, not these proposals. So we are now taking it to the rest of South Africa. And we are quite clear about this. So, there's no question in my mind. Now, for detail on this, please, if Alex is here, we'll all do well to listen to him for a bit about this. Thank you for the opportunity to speak.
Thank you, Dr. Aslam. I can quickly check if Dr. van Riever is here, just because his name has been mentioned.
I
see
think
that.
he's got something else.
Is that right?
I
Right.
understand, yeah, and I
Okay.
understand Alex has got something else on, and he's speaking on Thursday evening.
Right. Right.
Yes.
Okay, that's
Then we'll
great.
talk. Yeah.
I see Nicola has a hand up. I'm quickly going to give Nicola a chance to talk, and then we will get back to the Q&A again. Right, Nicola, you can continue.
It's a different Nicola.
Yes, this is a new one. Let's just see, Nicola. I enabled you. Participants. Yes, you can unmute yourself, Nicola. For some reason, there appears to be an issue here. Let me just try one last time. Yeah, sorry, I'm not sure why this is happening, Nicola. Please continue to add your question in the Q&A. I'm quickly going to proceed with the Q&A. Dirk asks, what is the constitutionality of determining fixed fees that must be adhered to?
No, that's for me. But it's a higher grade question.
It
so
is.
we need to first identify which constitutional principles could be violated by this. And remember, this is authorized by a law, the Competition Act. So the first question would be, is what is happening actually what is authorized by the Competition Act? That will be the first question, because normally if you limit rights, you'll say, okay, is there a law that allows us to limit rights? So let's say this is about the property rights of doctors, for example. So is there a law? And they'll say, yes, there's a law, and that law is the Competition Act. It allows that through this exemption process. The second question, however, would be, is that reasonable? Is it justifiable? Is it a proportional measure or not? So it's a whole complex assessment in terms of just the Bill of Rights. There could be other rights at stake and other issues at stake. So, for example, is it normal in a constitutional dispensation that the Minister of Trade and Industry, basically through regulations, give powers to the Minister of Health and to a whole range, the Council for Medical Schemes? Council for Medical Schemes have got their own act. So there's the human rights aspects and so on, but it's complex to assess that. But it's at face value, it would seem that, for example, one can say property rights or professional rights could be affected. And then the question is that affecting that limitation of the rights, is that justifiable or not? And then there's what we call organizational law issues, how government and the state is structured. That's also constitutional issues. So there could very well be a whole range of things.
That's interesting. Thank you very much, Elsabe and Dirk. Then someone asks, will the formularies not drive down the single exit price automatically, even though the single exit price is not included?
Yeah, that is a really interesting question, because that could very well be the case, that you get excluded from it. But the question is, because you're not a stakeholder in this forum, okay? You're not mentioned as somebody who will go and negotiate. How will you do this? How will you then say, okay, I'll lower my price so that I can be included in the formulary for diabetes treatments, for example? And that's the problem with this whole group of people who are not really part of this negotiation, but they're implicated.
Yeah.
So you could still, and that's the problem with the system. I think it talks about it being a maximum tariff. Now if it doesn't really, it's the formulary is now the maximum, and if it is, it doesn't allow you to be added to that, because then you become more than the maximum. So this is the, with a price that's easy to do. So I think that may be part of the idea, to see if we can lower the prices even more of the single exit price of medicine, or then a NAPI coded price or a list price of a medical device. But I'm not sure if it's fair to have this in a way that's not, you're actually not a party to this. And how will that work? I'm not sure that the pharmaceutical and devices industry, it's wise to say that now they can also collectively be involved, or will they be involved one by one? Because the rest is all collectively involved. So it's this implicated parties for me is a problem in this.
Thanks, Elsabe. Right. Somebody asks, Liam asks, is there perhaps comparative jurisdictions from which we can draw insights on the negotiation framework for tariffs?
I don't know. I think Nicola must answer this one.
Yeah, I'm not sure, actually. I haven't looked at the literature recently. I mean, the HMI, for instance, obviously refers to the NHS. So there would be some learnings that you can get from there. I think if you allow, Odie, I see there's a question here. Do you foresee benchmarking of healthcare pricing? Maybe I can rather answer that.
Right. Are you in the chat? Yes. Go for that.
Yeah.
Yes.
Similar to external reference pricing regulations for medicine. So again,
Yeah.
I think what is important is the lack of detail, obviously, in these regulations.
Yes.
But I don't think it will be similar to that, because as I've already mentioned, what needs to be done here, as is set out in these regulations, is tariff proposals must be submitted to the multilateral negotiation forum through the CMS. But you must submit all your data, and I think there are issues there around disaggregation of data and identification and everything else. And you must give supporting evidence that you want to rely on. This should include claim line data, cost structures, and then the CMS shall provide aggregate cost data and pricing data to the multilateral negotiation forum. So the issue is, it seems that the intent here is to do a bottom-up cost model. So remember, I also talked about the cost price margin here. So I don't think it's simply going to be some reference. It's going to be for each of these tariffs and every line item, really. It will have to be a cost bottom-up cost model, which I think is just going to be hugely complicated. I think the question is, do we start with the current rates? are those then subject to the price cost test? And then the other thing which I noticed is that everything must also be done through consensus. So I don't know how that's going to work if there's a dispute then in terms of the pricing. Then I think it goes back to the tariff governing body, which sits squarely in the NDOH.
Exactly.
So no, I don't think there will be reference prices. I think this is a much more comprehensive exercise at determining bottom-up prices for each and every tariff.
Let's quickly also deal with the question here in the chat. Are the regulations, well, let's say that the current block exemption in conflict with the Health Minister's draft regulations that propose establishing a uniform basic benefit package that must be offered by all medical schemes?
I'm not
Elsabe, do you want to
sure
take that?
what draft regulations that is. I haven't seen draft regulations on a basic benefit package or anything like that. Perhaps if somebody else could give us some information on that. I haven't seen that. I know there's been the talk on changing the PMBs to add primary care to it. That I'm aware of, but I'm not sure.
Maybe I can help there. So on the 17th of Feb, also in the Government Gazette, there's the call for public comments on the Council for Medical Schemes low-cost benefit option.
Oh, the LCBOs.
Yes.
Okay.
Yes.
All right.
So I think that is what he's referring to here, is the old report of the CMS. I think it's the 2023 report that's now finally been released by the Minister of Health. And that's what I referred to, is he laments, in his introduction to these, that he doesn't understand why anybody would buy them, but nevertheless, he puts out the CMS report. So I think this is what this question relates to. So I think the uniform basic benefit package of the, if I'm correct in terms of my interpretation of this question, so that's what I also referred to in terms of one of the HMI recommendations, is a single benefit package that you can compare between schemes. So I think definitely there's a role for a low-cost benefit option package. How that will dovetail with the NHI is obviously problematic, because the NHI still has to define their benefit package, and if the funds are not available, it will probably be a very, very basic benefit package. So I think that probably is not in line with the NHI purpose, really. But I think in general, it's a good thing to define a low-cost benefit option and a package.
Yeah.
Right.
And I think this comes from a long time. People would remember in 2005, there was the Low Income Medical Schemes, LIMS project. So, and the estimations are that there's 7 to even 14 million people that could be brought into the fold of having cover. So, but the minister doesn't want to do this. He's saying we're doing NHI now. So,
exactly. Because then you also need to revise your PMBs, which obviously is driving a cost. So that will have to be excluded out of that low cost benefit option.
Exactly.
Right. I'm quickly going to read what Heather Irvine said. She's a competition lawyer. Heather says the block exemption would allow certain firms to agree on tariffs and codes without any risk of prosecution by the Competition Commission. The block exemption would not compel any firm to engage in collective bargaining or provide a legal mechanism to force any firm to charge any price or use any codes which are agreed. However, tariffs or codes which are agreed by the funders and others collectively, especially if they have market power, might well become the basis or the maximum for what all of the funders are willing to pay for the products and services. This would impact markets or suppliers which are not included in the bargaining process at all. For example, the hospitals and medical produce suppliers. Is there any merit in granting a block exemption from the Competition Act should it not cover bargaining by all firms across the whole healthcare sector? Is there any merit in granting a block exemption from the Competition Act should it not cover bargaining by all firms across the whole healthcare sector?
Yeah, so I think Heather is saying everybody, we can't leave some people implicated and leave others out. And I think this is, so for me, this is one of the, we're trying to half fix something now through this. We're not going, even if we make everybody part of this, the thing is, what do we want to fix? What is the problem that we want to fix? And why are we cocktailing and cherry picking when we're trying to fix something? So, and I think there's going to be lots of unintended consequences. I mean, the wording in this document where they talk about enforcement and monitoring and so on, it's interesting because it kind of assumes that there's going to be somebody checking and the binding force of this. So I'm not sure that this is, if we want to fix the health sector, we need to look at this a bit more holistically, and not holistically, and let's just now assume exempt everybody. I think we need to look at what are the problems and what are the things and why are we where we are. We all go, oh, the hospitals and the specialists, they are cost drivers for medical schemes. That's a function of how the PMBs are described. The PMBs are defined in that way. So, we're trying to say, oh, they're so expensive or they take so much money, but we haven't addressed the underlying things. So, and I think that's my worry, that just making the circle bigger, let's just exempt everybody, I don't think that's going to solve the issue. I don't know, Nicola,
if I could just comment quickly on Heather.
Yeah,
so I think Heather's well placed, obviously, to interpret these from a competition perspective. The only thing I would add is that it says here that the multilateral negotiating forum should collectively determine maximum tariffs. Sorry, for PMBs and non-PMBs. I think there was an issue earlier whether it's a fixed rate or a maximum. But what is important then, if you don't opt in, so if you opt out, and you presumably that's possible, but then you will be caught by 918, which says that funders and healthcare professionals may engage in bilateral negotiations, but then you can only agree on a reduction. So that maximum will probably, in economic terms, then almost become the reference price. So I think people will ask that price, and by implication, then people who don't participate will also be forced, obviously, to charge that price. And they can only negotiate for a lower price, which I think doesn't make any sense. So I think that is probably how it would work in practice.
Thanks, Nicola. I am going to quickly read Shelley's question. How will practitioner groups supply all their data? Practices all have different structures, different costs, different efficiencies, etc. Would this require mass practice cost studies?
I think so. And I think back on living through that whole RPL process and having many professional society clients that have tried to kind of get something off the ground in terms of trying to determine that. But it's so varied. So I'm not sure if that's possible. And the thing is, the studies were done in the RPL case. I mean, people did do the practice cost studies, but it was rejected. So what do we do if we are in that situation again, where the practice cost studies is either rejected for methodological issues as to how it was done, or for low response rates? That we've also been there with a pharmacist on what is the response rate and why aren't people willing to disclose how many ironing boards they sell in the front shop versus medicines and stuff. So, or Lindor chocolates and medicines. So I'm thinking, this is why I'm asking about candles and cabbages. This is heavy stuff, and we've been here before in terms of just practice cost studies. Shelley will know; she's also been there, so it's not an easy thing. Nicola, I don't know from an economist perspective if, yeah.
No, that's why I said it's a very complex exercise, because you'll have to then, I mean, once you get the tariffs and the data, somebody then has to decide what is that margin that is applicable between the cost and the price. And that's why I say that is a very, very difficult thing. I mean, it's a typical thing that we have to do in competition economics, for instance, to determine whether a price is excessive. And one could talk about those cases ongoing, but that's the type of thing that you need to decide. You know, what is the return on investment? What is a reasonable profit margin that can be charged? So once the GP practice has submitted all their costs, then somebody must make a call on that. And how is that going to be determined? I mean, you know, what is the reasonable investment? I mean, for the moment, the hospitals aren't covered, but I mean, what is a reasonable investment on a multi-million-dollar hospital facility, for instance? So those are the difficulties that you run into when you try and regulate these prices.
Thanks, Nicola. There's a very interesting question, and Elsabe, I see that you are typing an answer to the question regarding whether you can still have a private fee. Is that something that you can share with the entire group?
No, I wasn't. I just had it open. I didn't.
Where? Okay,
answer. Yeah.
right. Yeah, it's a
So,
very...
yeah, to me, it seems that if you can totally opt out of the system, you know, then, but I think the problem will come. So currently, people who opt out says, I'm not contracted in with your medical scheme, but the people take the account and they submit it to their medical scheme.
Yeah.
Now that patient won't be allowed to do that because the scheme will just say, we don't reimburse at this tariff. And I think that's why it was designed in this way that people will not, to kind of force people to opt into the system, because your risk if you totally opt out would be high, because there will now be an agreed tariff code with a maximum tariff attached to that. And, you know, currently some of my clients who are, you know, if you don't bill what the medical scheme says they will fund, they pay the patient. And the patient then go and buy a flat screen TV. They don't pay the provider. So yeah, although it's possible, I think technically to opt out on what's written there, I think it will be hard to opt out. And as Nicola pointed out, it could come back to you if there's a bilateral agreement below that maximum.
Right. I see Dr. Aslam is responding to Andre Roux. And then there's just a last question. Will it be possible for healthcare providers, to opt out of the tariffs? Right. If not, this is a point on which the regulations might be challenged in court. But I hear what you say, Elsabe. There are some practical implications if you go that route. Is there anything good? Is there anything that one can work with these tariffs, with these exemptions? Are there anything that can be tweaked, that can make them somewhat workable? Or what do you think, Elsabe and Nicola? Must we go back to the drawing board in its entirety, as Dr. Aslam suggested?
Yes, I think, yeah, if I can go first. Look, I mean, to nitpick now and to take out things that might work is really against what the recommendations, you know, my conclusions when I spoke about this is that, I mean, we need healthcare reform. Clearly, we need that. We're already on the road to universal health coverage. I think most parties agree that we need something along that route. We need to do something about healthcare costs. Some of the issues in the private sector has been identified. I think my personal issue is that it seems to me quite clear what we need to do. There's been very good recommendations. I mean, one would be, it's been floated recently, one would be mandatory scheme membership for everybody that's formally employed. I mean, that's a simple thing. Then you enlarge your risk. So I think one needs to start with the sensible things first. Get your risk pool larger, spread your risk over a large part of the population, get the missing middle to participate in medical schemes. You know, So do the obvious things that have been on the table, fix those, and then see whether you still need, these kind of regulations. So I think you build it from the bottom up, and I think one should comment on these within the 30 business days and point out to the impracticalities and the piecemeal implementation of some of these reforms. And I think it should go back to the drawing board. I would actually then agree with Dr. Sue.
Thanks, Nicola.
My only addition would be ask for an extension, because this stuff is heavy. To collect your stuff, and just what it took us to collect the historic information on that. I really think it. Remember, regs normally is 90 days or 3 months. Sometimes it is, but I don't see the rush in this now.
Yeah.
So we need to be able to think this through for the implicated parties. We need to think this through because we all think specialists and doctors. We haven't thought about occupational therapy and all of that. And we haven't thought about what's the extent of global fee arrangements or value-based care currently. So
yeah.
So it's I can't see how we can do this in 30 days. And remember, we're commenting on HPCSA, we're commenting on LCBO, and we are commenting on the draft mediation bill, which is very relevant for medico-legal liability and malpractice, and also for international agreements, international mediation. So there's a whole lot of stuff on the go at the same time. And a lot of the people affected by this have got full-time other jobs, so to get their membership together to look at this. I would say that's the first thing that one should do, is to ask for that extension, because this is heavy stuff. This is important stuff.
Yeah, thank you very much, Elsabe and Prof. Nicola. This has been so useful. Thank you for sharing your insights, and for everyone who asked questions, and Dr. Aslam for contributing. Also, Heather, for your framing of the issue from a competition perspective. Thank you so much. And probably if the exemption survives and if we have to make plans, it would be great to have you here again to see how we can take it forward. But for now, it's been so helpful, and I really appreciate it. Thank you very much, Elsabe and Dr. Nicola.